your opinion and the way you really moved the addiction treatment
Well,
forward
Art,
in this.
you all I hear is music playing when you speak. I'm not sure. I love everything you say, but what's more important to me than any of that is that you're in the office of the ONDCP. I know who you are. I know how you know this illness we call addiction, and I'm so excited when your wife told me you're moving into that position. I thought, oh my goodness, this is good news. This is very,
Oh,
very
thank you
good
so
news.
much. Yeah.
Very good
Yeah.
news. And
But I'm
I'll tell
actually
you,
like in my third week of this position.
how is it?
I got appointed by President Trump probably 2.5 weeks ago. So it's been
Fabulous.
a real thrill of mine, and I'm very honored to be serving President Trump in this. I actually, in my lifetime with addiction, mental health, I think this president has put it on the front burner more than any of his predecessors.
Well, we can talk about that because it's interesting to me that doesn't seem to have come up much in the campaign, and yet I'm so grateful for, if you remember back in the beginning, and Susan, I'm not getting anything on the chat for some reason. So take a look at that. But back in the days of the First Lady's Opioid Summit, that really made a huge, huge difference. I know you were a part of that as well.
It made a tremendous difference. I think that was one of the first time something that's ever been held at the EOB, and you were the keynote speaker in that address. And I think that was an awesome event to bring forward a lot of great pronounced people in the field together to address that topic, that and the mental health crisis that this nation is exhibiting.
Yeah.
We're seeing right now, especially with bed shortages and that sort of a thing.
Okay, so now that you're in this position, well, let me first tell a story about how we met. We met because we toured the executive offices of there's the White House, and then across the sort of courtyard are the executive offices, and we toured the executive offices together. You, me, Susan, my wife, and Leanne Tweeden, who was my radio partner at the time, and you and I chatted up a little bit about the disease of addiction, and I know immediately when I'm talking to somebody who knows what he's talking about. And I thought, oh, I see you, Art. I see who you are, and I see what you're talking about. And I was grateful to remain in contact with you immediately after that. So, what are the priorities for the ONDCP? You've got an executive order, right, underway here?
We have an executive order that just got signed sort of recently, saving lives through increased support for mental and behavioral health needs. So what we're trying to do now is based on evidence that we've seen, and I have a lot of facts and figures here I could kind of go over with it, if you want me to. But
I may yet want that.
What's that?
I may want that. But
okay.
Tell me the broad strokes
I mean, I got it here.
The broad
but
strokes
we have
first.
A spike in overdoses, mental health, adverse symptomology, that sort of a thing, an increase in suicide attempts, all stemming from like the lockdown, or at least the prolonged lockdowns of what's going on. And then in your work that people start talking about social isolation, loneliness. Those might be social phenomenons that stem from the lockdown. But when somebody's predisposed to, say, the disease of chemical dependency, substance use disorders, and mental health, depression, they're actually clinical issues, right? So when you're locking somebody down, and I noticed in my work, I've even treatment planned for it. I'm a former clinician. I worked in, I got actually a long story with addiction my own self. And then I became a licensed clinician. I went through Hazelden, did my clinical training there. But so in my work, I've actually treatment planned for people who are had a social isolated existence or tend to try to be left alone and not want to be bothered, and which is actually a disaster for people who are suffering from a severe substance use disorder and those who are maybe struggling with clinical depression and that sort of a thing. So when you lock people down and then you started to increase the unemployment as businesses were shut down, not only are you isolating people, people, but you're also taking away their opportunity to develop meaningfulness in their lives. You're taking all that away from them. And so as you start to build these, and then people in isolation, a lot of times their thought processes, their cognitive processes will go negative. They'll start thinking themselves down into a funk. They won't have any sort of a meaningful existence as their employment is taken away from them. Mm-hmm. And one of the things that we're going to see is a lot of adverse effects. Now, the adverse effects could be increased self-medication, other sort of mental health symptomology. So that's what we did with this as we looked at the data and we looked across the country, and we've seen it in a number of categories, including domestic violences and sex assaults that are occurring in the home. We got together with my team in the White House at DPC, the Domestic Policy Council, and created an executive order for the president to sign to try to address this.
It's fantastic. I mean, I know you and I have been worried about this for a long time, and it's just been getting worse and worse. I want to break down your comments and ask a couple of pointed questions. What do you make of the World Health Organization coming out today strongly against locking down for essentially the same reasons? They prioritized increasing poverty, but the biggest problem with increasing poverty is the profound mental health consequences. Go ahead.
Go ahead. Do you want me to comment on that first? I love that they did that. That's music to my ears. I could say they, I'm not going to look a gift horse in the mouth or anything, but could they have done that earlier? I don't know.
Let's put the timing out of it. Let's just be thankful they're there now, because they've been quite, there's a few people out there representing that have been quite powerfully vocal about it, and I thought, all right,
good. I'm glad. I'm very happy for that. I'm very happy for that.
Yeah.
And I'm very, like I said, I know the disease. I got a little over 18 years clean myself, and then I worked as a clinician. So that's very valuable to actually step out the way they're doing, and I welcome them tremendously to this effort.
The other thing, the description you painted about how the lockdowns are affecting people with mental illness. I can't remember who said this to me. It was somebody last week. I think it was a recovering person who said, the lockdown has made everybody live like an addict. It's like it's all the behaviors of addiction, the isolation, the obfuscation, the fear, the shame. I think might have been.
I'm glad you mentioned the shame, because that's huge. That's a huge piece of the shame. Yeah. And I don't know who said that, but that actually sounds pretty pertinent, on point, the way I sort of describing it. You are actually making people live like an addict in a lot of ways. They like the term addict, but, and you'll get people, and they'll show up in treatment, who have been sort of like clinically isolated. And it's almost like I don't want to say intentional, but the disease of addiction actually tries to cut people off from the loved ones around them. So that's kind of like you would work in treatment, you give them a treatment plan, you do evidence-based practices. But one of the best things you do is you click them into a community of people, right?
Yeah.
And then they get in modeling behavior. They're starting to kind of interact with other people, and it becomes a very sort of health promoting endeavor. But you need other people in there to make it work.
I'm laughing because I'm not going to step down. I'm not going to stand back from my own sort of experience treating this addiction for this disease for 35 years. And let me just, I'm going to be really unfair to you. I'm going to put you in a hard place.
That's fine.
And I'm going to say, when you go to your meetings, do people go, I have a substance use disorder, or do they say, I'm a junkie, I'm a drug addict?
Well, I know what I say. I have no problem saying I'm a junkie.
Of course not. Of course not. Everyone in meetings, and you laugh about it, and you talk about it.
I'm fine with that.
Thank God you're recovering from it.
Yeah, I actually think being able to laugh about it is one of the healthy things you can do.
Oh my gosh, yes, that's what I love about treating addicts. They're so funny, so funny.
And I think people sort of miss that. It's the whole point of sometimes you go to a speaker meeting.
Yep.
So it's that relational stuff. You can kind of, sometimes I would actually call like group therapy, like one of the main things about it. Yep. It's like a de-shaming exercise, right?
Yep.
You can kind of get this guy to relate. There's a catharsis. I did this, you did that, I did that. And then it doesn't have so much weight or bearing on somebody to where they need to duck and hide and anesthetize themselves and that sort of it.
I've never met a drug addict that felt stigmatized unless he or she was using stigma as a way to keep using. Families feel stigmatized. The families
Okay.
do for sure.
That's why you and I are on the same page a lot, actually. And I hate to say this, but actually, when stigma will show up, a lot of times when I'm working, and I work with people who have multiple overdoses,
Of course.
it becomes
Me
a
too.
bridge to foreigness in recovery, right?
Say
So
it again. It comes a
well, stigma sometimes shows up. When it comes to getting sober or
yeah.
into recovery,
Right.
it never really barred somebody from getting high.
Right.
The way I sort of
Right.
seen it, I
Right.
hate. I know that kind of a little counterintuitive to what a lot of people were saying, but it's usually stigma shows up when it's a preventative from somebody. Oh, I can't do such and such. That's kind of, I used to call it a bridge too far.
Right.
Get into recovery because of this or that.
Okay, right. Well, they'll
Never,
use the disease will use the disease will use anything to keep using, and anything to sustain itself. And as
exactly.
everything, other
Exactly.
relationships, other qualities that we have, intellect, whatever it might be. It's all
Exactly.
used by the disease.
Exactly.
And people don't. It's outside of consciousness. It's because of the broken motivation of the illness. And but families and codependents do feel stigmatized for sure. And believe me, I'm an advocate. I'm marching against stigma all the time. And let me just state it very, very clearly: we should never treat illnesses below the neck different than diseases above the neck. Period. End of story. And the fact that we shroud psychiatric illness in special HIPAA privilege and special courts, that's adding to stigma. Everybody treat it just
Right.
like your heart, just like your pancreas. That's how we should treat it. And so that will reduce stigma anyway. And also the other thing in reducing stigma is contact. So all the people you see in the street, reach out to them, talk to them, make contact. They won't be people. You won't be so stigmatizing. You won't be so uncanny in your relationship with them, and you won't be so afraid.
One of the things too, and I talk to some people because people come in to hear we're the government and stakeholders when I come in, and so one of the things I say you could do a lot of times too is like when we're at treatment service work and doing pro-social behaviors out in the community,
Sure.
and then seeing this population where we're a treatment center and they were stigmatized, they didn't want us in here. And I tried to open up an outpatient one time, I got run off. They didn't want these kinds of people in the neighborhood.
Oh yeah, that's
So,
terrible.
so I'm aware, I've
Terrible.
seen it, but like if you could get sort of like you're out there doing some service, doing pro-social activities, not only does it make the person feel better about themselves, but it also changes the way the public sees them at that point in time. And seeing that actually also reduces stigma, and it's something they could do for themselves to reduce some of the stigma.
Right, of course, by being pro-social, and by the way, that service is what will build the cornerstones of recovery. One of the things about the opiate summit was the Justice Department got very involved with that. And I remember sitting there, and Jeff Sessions says, I'm going to get this. I'm going to stop these doctors from overprescribing. And I'm telling you, he went after a few, and doctors froze. That's kind of how we work. When there's a legal action, we just stop. And because we don't have time to figure out the nuances, whatever. We just we're doing our job. But the overprescribing message got received. And it really was because of the Justice Department. So, and of course, there was a lot of really good, multiple different layers to that initiative, all of which were quite good. But what are the operational pieces of what you want to do as the part of the executive order?
Well, we're going to put together, we're looking at vulnerable groups, whether it's, certain minority communities, hardest hit, elderly, that sort of thing, veterans. And we're also going to be modeling against the president signed an executive order a while back, prevents, which worked to address veteran suicide. So we're bringing in that piece. We're going to see if we can model it, but we're putting together an interagency sort of work group. And we're going to address things such as like trying to encourage more face-to-face meetings. And I have a lot of, I have some statistics from the Addiction Policy Forum as far as that's concerned, and then I reach out to my other sources anecdotally that are going to meetings. But that's something I think we need to really sort of stress. And so we have like a broad group of, USDA, SAMHSA,
Right.
Department of Education, we Veterans Administration, So we're bringing in the heads. It'll be headed, chaired by the Secretary of HHS. Now, he probably have a designee chairing that that's actually very skilled in this matter. So we're going to be meeting and in developing strategies, whether with grant formulations and that sort of thing, on how to encourage more togetherness, more face-to-face allowances, in eliminating, hopefully addressing the problems caused by the lockdown. Now, it's great that the WHO, I welcome that they are now professing to want to end lockdown. But as you know, and I know, there'll be a residual effect, because when somebody, let's say they incur a trauma, just because the trauma stopped doesn't mean that they're good to go. So
Right.
we'll be having probably some residual effects for some time being. So marshaling resources to address this, I especially like this point in time, I think is, I'm very happy that the president signed this and he sees the value in this.
And you're going to have a meeting. Tell me about the meeting. An
The
event.
meeting,
The
well,
event.
excuse me, I'm sorry.
Yeah,
The
the
event
event in
is Thursday?
Philadelphia? The event in
Yeah, we're
Philadelphia?
having a big event. You were welcome, but
I know. I wish I could
we'll
be
get you,
there.
we're gonna get you back again. No,
Believe
you're
me.
not off the hook.
I know.
So we're having a big event. It'll be chaired by the Second Lady, Ms. Pence, who's spoken a lot about suicide prevention, mental health. We have a couple of experts, well, a number of experts. We have John Kelly from Harvard, who will
Oh,
be,
great.
yeah,
Love
yeah.
him.
So we're doing really well there. So we
Yeah.
have the Second Lady. We have Dr. McCants Katz, who's the Assistant Secretary of SAMHSA. She's also a psychiatrist
Hmm.
and got over 30 years experience working with this. So we have a number of other people too. We have I'll give Katie Sullivan from the Justice Department will be there.
How about that?
Yeah.
How do you know her?
I gotta get that in there, right?
Shall I tell them the connection, or do you want to tell them?
Well, what do I think I should do? Oh, I'm very fortunate to be married to Katie Sullivan, who
Right.
runs the Office of Justice Programs at the Department of Justice. And one of the experiences she brings is we're seeing like an increased rate of domestic violence. As you lock people down, liquor stores are open, so that doesn't really go very well. And then we're seeing an increase of sexual assaults in the home. And that, for like the first time ever, the RAIN line, the rape and incest line, are seeing more juveniles calling than ever before. And then as schools are shut down, mandatory reporters, school counselors, say extracurricular coaches and that aren't able to kind of intervene on some of this. So that's something that we're definitely looking at.
And let me toot Katie's horn for a second, because she was a judge, or she is a judge, and she understands the hard work of holding people, holding the boundaries and holding them accountable and getting them well when they end up in the criminal justice system. She actually, rather than enabled or pushing them into the prison system, had various kinds of interventions that really got people into recovery. I mean, she's a genius of that. So I hope she'll talk a bit about that.
Yeah. Yeah, she will. I mean, she invented it from scratch, but her own drug court program there in where we were at in Colorado, and is sort of very successful. And you're right. Her main emphasis of the drug court was getting people into recovery. And kind of a lot of similar philosophy to me. It's not just about getting sober. It's about taking your inherent abilities, talents, your intrinsic value, and applying it towards life, and then making something that you're capable of making, finding love and joy and that sort of thing.
For sure. And she was willing to hold the line and not tolerate the BS and the manipulation and the obfuscation and all the usual nonsense. She didn't fall for any of that, and she kept the patients moving forward. It's incredible.
She did a tremendous job in that regard.
Mm-hmm.
Actually, she's very wise to it and very hip to it. So kind of trying to pull one over on her isn't all that easy.
Yep. Yep.
So
she's also, it took me about 2 minutes of talking to her before I thought, oh, she understands this too.
She's a huge fan of yours. So.
Well, I'm a fan of hers, and it's not often. We have this world of very kind of cloudy, goofy ideas about addiction, and I'm not saying that our approach is the only approach, but but you have to really understand the condition. And I can always tell when I'm around people that truly understand it. And even with my depths of understanding, I need somebody like you standing behind me, kicking me every once in a while when I start thinking like a normie and miss the priorities of addiction, which for a normie, it's hard to keep that in your head all the time. It really is, because it's not intuitively obvious. I mean, the typical thing for me is I would come out of a, really deep session with a patient, and I'll, talk to my staff who are all recovering people. And I go, yeah, she was talking about her mom and the abuse, the first time she ever talked about it. And they all look at me and they go, yeah, she wants you to prescribe some drugs. Yeah, she wants meds. It's like, I was like, oh, God, again? Damn. So there you go. And they're never wrong, by the way. I've learned to trust my peers. Not to say that it's not important to talk about the traumas and all the psychological stuff, but when people are deep in their disease, that just serves the disease. This is the artistry of treating the condition. You have to do everything in the right order and the right time for that given individual. But you always have this disease lurking up front. What's that, Art?
No, I agree with you. And this is a little counterintuitive too. You have to sort of, some people want to show up, they had trauma, and then you end up trying to chase the trauma,
Right.
and then the disease of addiction sits over here.
Yeah.
So a lot of times people are more apt to, my trauma,
Yeah.
and then they'll leave this piece over here, and it's kind of like, wait a minute, what about all this sort of addiction? And just because you deal with trauma doesn't mean the addiction goes away. It actually, the disease, as you know, takes on a life form of its own. So that's what they mean when they say that it's primary. It doesn't necessarily have to be caused by anything, but once it's there, it becomes a primary illness. So you're right. You have to kind of put that in because the most life-threatening, most acute problem is going to be the substance use disorder, the disease of addiction. That's the most life-threatening ailment that they have, that they're presenting with.
And for those of you that are listening to our talk and to go, why does it have to be a disease? Let me explain. First, do you have a definition of disease? Just think about it. Before you know whether this is a pen, you have to know how to define pen. And same thing with disease. What makes something a disease? And it's a rather complex definition. So let me just throw it out there. It's the relationship between the environment and the genetics of the individual. So the environment-substrate interaction, complicated right there, that ends up in an abnormal state of physiology. We call that pathophysiology. That pathophysiology is reflected in signs and symptoms. So somebody like me looks at them and we know, therefore, that pathophysiology is going on. That signs and symptoms will follow a predictable pattern. That pattern is called the natural history. And then people like me or Art try to change that natural history in a positive way with something called treatment. That's it. That's all disease. That's everything.
That's a great simplistic definition of it.
Yeah, and people go, oh, well, where's the Koch's postulates? Where's the infection? It's in the brain. It's in the shell of the nucleus accumbens. We know a ton about that biology. And just because you can't see it doesn't mean that's not where the disease occurs. And it only occurs in the genetically prone, primarily occurs in the genetically prone individuals. People with dependency without addiction, as I think about it, there's various ways that we can, parse this, but you can become dependent and look like a drug addict, but when you are taken off the drug, you're not interested in continuing. And that's not the kind of addict that Art and I are talking about here.
Right. I that's a good distinction. I used to kind of tell that to sort of my clients. In fact, there's a movie, The French Connection 2. I used to use this as an example where they took French Connection, they were heroin, it was back in the 60s, 70s. They chained him to the bed and they kept walking in there giving him a shot, right, of heroin. And eventually Gene Hackman was begging for the shot. But once they kind of withdraw him and everything, then he's not running around trying to get another shot. So that's a little bit of a difference, sort of like with somebody with the chemical dependency or disease of addiction. After they have this consequence or something like that, they're going to turn around and run right back to it, right? So that's a little bit, that's kind of what you're saying, that is actually a difference. Or like when an elderly person gets prescribed opioids or something, they might develop a physical dependence, but not necessarily swerving into severe substance use disorder. And you wean them off, they could be good to go.
Yeah, exactly. And with all the overprescribing we had, in recent years, we saw a lot of that. We used to never see that. And then all of a sudden there was a bunch of it. So, all right. So let's get back to the the increased support you mentioned, that's a pretty sweeping statement. I want to know
Okay.
what's packed in there. What is the increasing support for these mental health initiatives?
Well, we're going to work with the heads of every one of the agencies, and we're going to develop with the grant programs. I don't have it sort of with me, but we're going to.
There's money. There's money. Point is, there's money to do what? Give me sort of sweeping ideas about. There's going to be money to educate, to treat.
We're going to put up we're looking at ad campaigns. And we're probably going to tweak that out a little bit and try to get a different type of ad campaign where people can actually know to seek help and that sort of a thing.
Yeah.
But we're going to work with education, and we're going to work
some of
with,
it, I'm imagining some of it you're going to determine at the conference, right? Some of it's going to be some of it you're going to develop at the conference, are you not?
Well, we're going to develop some of it at the conference, but we're also looking to highlight the work we're going to be doing. And what we're trying to do is we have permission from the President of the United States to get together and produce a working group as we're going to devise strategies based on the data that we presented to us. And what we'll do is we'll analyze grant making authority and that sort of a thing from across the federal government to address these situations. So really what the executive order is doing, like up in front, is we got the executive presidential authority to create a working group to address the fallout from the lockdowns of the pandemic. Exactly what all of that's going to look like, I don't know yet. We have OMB on board in that. So we're definitely going to do our best to address this situation.
Art, I am sending you a little video series that I thought was so good. I'm going to email it to you. It's by a group called Healing Minds NOLA. It's from a group in New Orleans. Come on.
Yeah, you said NOLA, so yeah, that's my hometown. NOLA.
Okay, you'll love this then. And they essentially were so there were two summits. One was a sort of a mental health homeless summit, and the other was a opioid summit. The one I spoke at was the. Do you have a different email address now, or can I send it to the same one?
So I'll have to.
I have it.
You have it? Maybe I'll send it.
I do. It's lengthy. Somebody's going to send it. Natasha's going to hit you with that right now.
I'll forward it.
Yeah. Okay. Yeah. Better for. Yeah. I'm seeing if I have a.
Yeah, but I'm born and raised, so that's a big deal for me.
Yeah. So let me just tell you that they took I don't know if she consciously did this or it's just my own construct of what she did, but every point I made in my lecture, she went and got experts and developed them out, and really got deep in the weeds about the IMD exclusion and about assisted outpatient treatments and all these different things that I talked about. And I'm going to send you the video series, a whole series of videos that are quite good.
Those are on the table, by the way, the expansion of those as far as this executive order is concerned.
Yeah.
Well, thank you for bringing those up.
So, but I'm going to give them a talk later in the week, and I've been thinking a lot about what I was going to say, and I started thinking about what a mess it is here in California. I'm driven absolutely insane by the homeless situation because it's my patients out there on the streets dying at an extraordinary rate. We have essentially negligent homicide being committed by our government, and I thought at the very, very, very core. There's lots of things around, we can talk about. But at the very core, doctors, and I'll put psychologists in that group too, and you might appreciate this as well as a KDAC, as a chemical dependency counselor, medical providers are prevented by law from treating their patients. That's at the core of the homeless problem. We can't obtain any sort of court support for assisted outpatient referrals, for conservatorships, for
you can't do that in
intervention.
California.
What's that?
In California, you're pretty much barred from that.
Where you can't get anything done. And you have laws that make drug use legal, trafficking legal, stealing legal to support your habit, and then a complete inability for us to deliver care. And that's really at the center of this. We need to find a way that clinicians are once again empowered to every other country on earth. Let's doctors take care of sick people. But particularly in California, we've decided we're too good for that. And it's murderous. It's homicide. It's negligent homicide. And I don't know. I just want to put that in your thinking cap to kind of go forward with.
I got emails right now. I've been trying to circle back, and then we talked about this. I've actually want to kind of go out there and see it for myself. I haven't been to California lately. Been dying to get out there.
Art. Oh, my friend.
I'll probably put on street clothes when I go do that. But
you have to put on more than street clothes. Trust me. Okay, I'm sending.
Because I have somebody from one of my contacts at HUD. I know that they have a couple hotels now where they're putting. And I think one of the hotels they had a meth lab. They found it.
Yeah, of course, of course.
And then what is it? You could shoplift under $950 out there. Is that?
Yeah.
Yep. So Art, just put yourself in that position. What if you were an addict using your using days, and someone said, "We're not going to hassle you if you use. We're not going to hassle you if you traffic below a certain amount." And walk into Target. They're not going to hassle you. You can support your habit that way. You coming to California?
Yeah.
You know what I'm saying?
That'd be great, right?
And then unfortunately, it would be bad enough if it were just opiates on the street, but meth is the major.
Right, and that's
drug.
actually,
Yeah, go ahead. Ugh.
We're seeing it now. I just recently took a trip to the border, and they're seeing more and more meth coming into the country, seizures and that sort of a thing. Meth is actually gaining, and unfortunately, popularity. But to your point, I kind of think a little bit of it when I was in New Orleans. I don't know if you ever saw that show, The Pharmacist. It was on Netflix.
Yes.
You saw that show?
Yeah.
Okay, so that was my era. The last couple of years of my using was in that era. And what The Pharmacist doesn't show is that doctor there, Clegg, had competitors. And she had competitors that actually franchised herself. It franchised. So you could pay people to go to the doctor, and you could hit all these multiple clinics. And so basically it became just a drug emporium, and all of those were like legal transactions. So what you're describing to me, when you make that legal aspect of it, is really the advent of the opioid crisis. So what's going on in California is like almost
extension.
Maybe that on steroids.
A continuation of that.
Yeah, right.
But it's now because the pills have dried up, it's switched to fentanyl and heroin, and the basis. I have a whole lecture on this, but the basis is that a discipline in medicine, a professional discipline, took the position that pain is what the patient says it is, and pain control is what the patient says it is. Therefore, you don't need a doctor or a nurse. The patient decides. And this is much like, the stuff we do out here in California now in terms of letting people use. When my patients found out about that, it was on. It was on, man. They were on their way to Florida.
Yeah, exactly. You can't compete with that.
Right. Pain is what the patient says it is. Pain control is what the patient says it is. There's no such thing as drug addiction to opiates. They also took that position, by the way. They took the position that addicts were bad people, a behavioral disturbance. They were extremely stigmatizing of drug addicts and supporting and killing drug addicts all along the way. It's terrible. It was a terrible time. It's a lot better
I think,
now.
that's actually, it was amazing back then. And like The Pharmacist does a good job of depicting that, if anybody sort of saw it. But what it only shows one part of it. It was like really, I call it the Wild Wild West back then. It was actually sort of insane, and it was like very hard to put that genie back in the bottle. And kind of like what I was saying, once you kind of started that, it's people, the pill mills aren't there, I better quit using. It doesn't kind of work that way. It kind of goes on, and I'm not sure exactly, when I think about California, I'm not sure exactly what they're trying to create with the policies that they made.
It's what I keep asking. What are you doing? What is the goal? Towards what ends are you killing between Orange County and Los Angeles County? You're killing 5 people a day. Think about that. That's 1,500 people plus a year dead of a treatable illness that they are blocking our ability to treat and creating every legal pathway to death. It's like, what do you, I heard a politician yesterday say that going to Sacramento, is like that that Geico commercial where these kids are being chased by a chainsaw murderer, and they go, maybe we should go in that car with keys in it running over there. And they go, why? Well, don't do that. Let's go over here. And they go in the shed behind the other chainsaws. And, and the next cut is the chainsaw murderer with the hockey mask, putting his mask up, going like, what? You got to be kidding. That's what politics, that's what the state of California has become. Something else.
And the shoplifting permission, some of the reports I got from California is that now they're able to kind of make shoplifting gangs, right? So $950 is a lot.
Same thing. Apparently, so I'm watching my chat stream here, and somebody just told me apparently Washington and Seattle, it's the same thing. Which, guess what? There's massive problem, massive death up there. Yeah, it's mind-boggling.
That's kind of what I talked to you about a while back. Like we did another summit, I would like to kind of, I used to do it a lot in my work, but with parents, the difference between enabling and helping. So I don't, I see that as totally enabling, which isn't okay.
Of course.
As opposed to helping.
It's now to the point of negligent homicide, but you know who's an expert on this topic. You know somebody who's an expert on this topic, and that is Katie Sullivan. So right? Yeah. So I mean, I love it when she talks about this and her experience with it. So maybe I had to get her on the stream here too to talk about that.
I could have. She's not here with me.
No, I know. I don't mean right now. I mean, I'll invite her.
She'd love to talk to you. I can tell you that.
Yeah, we'll get her in here.
She's probably a little bit jealous I get to talk to you today, but yeah, she would love to talk to you.
All right, because I love her stories. Her stories are really illustrative and good, and tell us what it could be, what we could do if somebody who understood what they were doing was actually listened to.
Well, like in treatment, sometimes I would say this is kind of missing. I would say the gift of no, right? So, hey, can I go and do that? No. Can I skip work today? No. So it's like holding boundaries, and that's what Katie does.
Right. It's hard work. The easiest thing in the world for me as a doctor, the easiest thing, open my prescription pad. Boom, done. Patient's happy. Move on. Yeah. Out we go. As opposed to, I've got a demanding, a very uncomfortable, suffering patient in front of me, and I say, here's what you need to do. Do you think that's fun? I get 10 minutes of, I literally had patients push their nose into mine, scream at me, and my job is to sit there with them and get through that. That's my job. It's very uncomfortable. It's very hard. It's why you need a team, because you can't withstand it yourself too long. As a recovering addict, you kind of know the games and stuff. As a normal, you can get undermined really easily. Right. And it's hard work that nobody will. Well, you have to know how to do it for one thing, because you have to have your feet under you the whole time. But you have to understand the value of it.
I think that's one of the biggest lessons to learn. And sometimes I would tell folks, their parents, that to do a lot of family counseling in that, or spouses. You could tell how far along and the progress they're making by the way they handle the word no. So, hey, doc, can you write me this? No, but they're going to spin out, keep arguing with it. You would know they sort of have a ways to go. So that's actually one of the emotional immaturity, but one of the when you start to seeing them moving into the right venue towards recovery is how well they'll handle being told no.
Well, that, and then you can start to use things like humor and go, dude, come on, you want me to prescribe you? And they'll start laughing with you. They're oh, geez, I am funny, aren't I? Because they don't really know they're doing it. They're just doing what they do. The addiction is an automatic thing, and when you call it out and laugh at it, they can laugh too.
Yeah. It is automatic. It's in the whole negotiating and that sort of a thing. A lot of it, like the defense mechanisms, like you mentioned, you mentioned it earlier when you said intelligence, right? So you could have a very intelligent person, and what is the addict within them is going to take that intelligence and sort of use it against them, or try to make it like okay to go out and be. I call it self-destruct.
And if you're a well-meaning person that cares about the person with disease, your brain will get used by the disease as well, which is why you need Al-Anon and programs and people around you to keep you from getting sucked in, because you will. And I do like I just said, I mean, if I don't have recovering people around, it gets I can lose my way. It's a cunning, baffling condition. But let's go back to the more global mental health stuff.
Okay.
So are you going to be focusing on serious mental illness as well as addiction?
We are 100%. That's kind of, we have Dr. McCann's Cats, who's going to help us with a lot of the expert on serious mental illness. I worked with it too, and we also have Barbara Dolan, who's helped put up the Prevents program for veterans. So we're gonna deal a lot with the serious mental illness as well. And as you know, I mean, like taking somebody with serious mental illness and then shutting down their supports.
Right.
Is not going to turn out well, especially.
So,
and then I know that the president, we did a lot of great work with the telehealth, but you have somebody with schizophrenia and that sort of a thing, or, a younger, say 25-year-old person with severe substance use disorder. Telehealth is going to be very hard for them to get the kind of treatment that they need. I mean, it's almost the whole point of the schizophrenia, the mental illness.
Humbly, we have to expand and motivate assisted outpatient treatment, right? We need either residential and AOT, right?
I think that would go a long way. Yeah. I'm a big fan of that. That's sort of like the principle of drug court, where you kind of have, structured into it. It requires structure. Yeah. Even with serious mental illness, you got to kind of build a certain routine for people so they can actually function and know the rules and the boundaries of where they're going.
Right.
Too much like that freedom sort of thing with no alternatives is not going to be there.
It kills. It kills. Let's be quite clear about it. Let's not mince words. It kills.
Yeah.
And so we need more assisted outpatient treatment. We need more residential treatment. We need more ways to motivate care. We need more psychiatrists. Are you guys helping with that at all?
We're doing a lot of workforce expansion here from the whole sort of government effort. At ONDCP, we're working on expansion of the treatment workforce, as is HRSA. Right. And there's other activities going on at, I don't know if you heard of HRSA, but Health Resources Services Administration. They're doing a lot of work. They have a lot of money. They're building it, especially like in hard to reach rural areas and that. So we're working to build that up. And we also have, SAMHSA has the ATTCs, which is like free, where people can go online to build up their educational sort of resources. But we've been working hard to build up an addiction treatment workforce out there. I think it's coming along. It's going to be, as you know, a long-term goal. Yeah. But it's something we've been working for.
Somebody asked a very pertinent question on my chat stream here: is eating disorder a disease? Which prompts me to talk about the difference between a disease and a syndrome. So a disease, I described, there's a common genetic link, there's a common and unified pathophysiology, and their characteristic signs and symptoms. A syndrome can have varying genetic bases, and to be fair, addiction has different genetic bases to it as well, but the underlying pathophysiology is varied. So fibromyalgia is a syndrome, not a disease. The question here is eating disorder a syndrome or a disease? I think eating disorder has a multiplicity of underlying biologies, so it's more in the syndrome category. High blood pressure, hypertension is caused by lots of different underlying biologies. It's a syndrome. But addiction has a very specific common biology, very specific signs and symptoms, very specific natural history, so it's more disease than syndrome. Really
a syndrome. Can I get what was the syndrome again?
Syndrome would be like hypertension. You have high blood pressure, but many different things can potentially cause that. Multiple different physiologies, even different diseases cause the syndrome of hypertension. Eating disorder is sort of more a syndrome because there's not one common biology under eating disorders. And the signs and symptoms are a little varied, natural history is a little varied, but addiction is one biology, very common, specific signs and symptoms, particular natural history. That's addiction. Now we can parse it up with substance use disorder, binge intoxication, intermittent, chronic, acute. There's other ways of looking at it, but it all has that common biology underneath it.
Well, I think it does. When I get questions sometimes when I've been in government. Sometimes I think they try to, people want to classify it by drug of choice, but when you're, and the treatment program, I don't say drug of choice is irrelevant, but really what you have people doing when you're in group therapy, they're relating to the disease and not as much relating to the drug. So I could have an alcoholic, a guy who's primary cocaine addict, a methamphetamine addict, and heroin addict, and I'll put them in group together.
Right.
Right. So it's because they're relating to the disease and the core issues and the experiences that they have.
Right. The way I think about it is the drug of choice determines the natural history. Because each drug has sort of its own natural history. If you're a meth addict, you get psychotic, you start getting paranoid. If you're a cocaine addict, there's a binge intoxication cycle associated with paranoia about uniformed professionals. That's the preoccupation. If you're an opiate addict, it's, progressive and dependency. Yeah. And each one has its own specific natural history. But underlying it, that shift from the liking it system to the wanting system fundamentally is the biology of addiction.
Yes, I agree with that. You would see like little different behavioral differences in it. Yeah. Like the opioid addict will have a different behavioral preferences that they have to do. The drug dictates a lot of that. You got to get up early in the morning or you got to get sick and that sort of a thing. The alcoholic will have maybe a little bit sort of a different type. But as you're saying, what you're treating is the underlying disease of addiction when they go to treatment. That's what you're treating.
Robin asks a decent question. Where is it now? She says she has complex PTSD. What about complex PTSD and addiction? 2 diagnoses, 2 different courses of treatment. But you can't get at the trauma and the PTSD until the addiction is managed. That's the one that's going to kill you. That's the one that is interfering with our ability to treat the PTSD and the trauma. So you typically put the treatment of the addiction first. Again, I want to keep going on serious mental illness. Is there any look at I'm sort of frustrated with the lack of resources for serious mental illness. Are we going to be urging states or counties to be developing more resources? Are they going to be
We're
to money?
At
Go ahead.
The increase of also the CCBHCs, Certified Community Behavioral Health Clinics. That I know we are looking at expansion of the AOTs as well. I don't know how much of this will swerve into, like, say, a drug court type of model, but we are looking to expand. It wouldn't be like maybe a mental health type of model of court, but looking at that as well, working with the Department of Justice. So we are looking to expand. SAMHSA has the mental health block grant. Given the corona, they with the CARES Act, they got over $425 million to expand treatment capacity. So we're looking at all of it. We could say we want to expand models, but like you said, workforce is very important. Getting more people into the field or physicians. Probably go a long way too, helping to get physicians that I'll say better trained in the disease. But I would like to see that for a number of them. That's probably something
I know we need
better than me. But
happy to help you on that.
Looking at that as well.
We need a lot more of that. But we also need more psychiatrists generally, because serious mental illness is just undertreated. It's not. Doctors can't treat it. There's not enough doctors to treat it. There's not enough AOTs, not enough residential beds, not enough acute beds, at least in most states.
Well, maybe, I was looking at the IMD. I don't want to get ahead of myself, but,
yes.
I advocated for it. So there is some motivation to, we'll see how that comes out.
So I know what we're talking about is the Institution for Mental Disorders exclusion, the IMD exclusion it's called, for Medicaid and Medi-Cal won't treat people that go in hospitals for serious mental illness, which is the most insane thing we've ever done. But it was done in the 60s and is held ever since. When I was talking to somebody from the Economic Policy Committee of your domestic policy group, I guess there's an economic group. He looked at me and he goes, "Would it make a difference if I could change the IMD exclusion?" I go, "I would change everything. and then nothing happened. So
Like,
good luck, Art.
like we sort of like maybe temporarily to get, because when you're talking about California, most of those people, if you're sort of doing it, they're going to need at least some detox and that sort of a thing to kind of start to address that. And really, I worked, I would say, in a number of settings, but I would get periodically somebody who's more acute illness with serious mental illness, and the addiction was secondary. Now, I kind of equated, I attributed that to the fact that it's a little harder. It's easier to get them into like a substance abuse treatment center sometimes than a serious mental illness thing. So then I would be getting somebody like in somebody with schizophrenia, they have a totally different sort of use type than say somebody other than that, whose primary illness is that. So you would get somebody like that, and then they become very hard to treat in that capacity. And not only are they hard to treat in that capacity, they're almost hard to refer from there. Right. So you could have somebody show up in my chemical dependency treatment center. Now we have dual disorder capabilities, but as long as the chemical dependency was the more acute issue.
Right.
When it becomes sort of serious mental illness, the more acute issue, it's a whole nother.
The bottom line, Art, is that the patients tend to get the treatment for which there are resources available.
Yeah.
It's the way it works. And that's awful. I could tell you horror stories about insurance companies and what they've done to me over the years. Just unbelievable stuff. But for another day. One last thing. I would like to get rid of the term homelessness. Let's just call it untreated serious mental illness, because that's what it is. We shouldn't be calling people homeless, because that suggests you get them a home and you're done, which nothing could be farther from the truth. We just need to call it, or sort of the open air serious mental illness or something, because it is not about homelessness. I mean, they need a place for sure to be delivered care, but that the environment of care is just one little piece. Ugh.
No, I have an example. I don't know if people always follow it, but or can what I'm trying to say. But like even one of the I worked in a place where the people had means, or somebody had some money, right? So they would have a serious disorder, dual disorder. And I would always want them to go to recovery house, sober house, or refer them to halfway house type of thing. If they talk somebody into letting them get an apartment, so they got a roof over their head, they're leaving treatment, roof over their head, we generally, or you would end up with like another crack house in the neighborhood, another shooting gallery. So like a roof over their head isn't going to be alleviating the underlying causes of what you're talking about.
And here's what the rhetoric is here. They go, well, we provide them wraparound services. Well, now you're organizing a psychiatric hospital, because non-psychiatric patients don't get wraparound services. Wraparound services are something we gave in a psychiatric setting. Social worker, psychologist, psychiatrist, vocational rehab. That is comprehensive psychiatric care. Let's call it what it is. And let's organize it explicitly, because calling it wraparound services sometimes is just somebody driving by once a week and asking how they're doing, versus what they really need, which is comprehensive psychiatric services. Art, I gotta kind of wrap things up. It is, it
was great talking to you. I really appreciate you letting me come on.
Of course, anytime. If Susan, tell me if this is not true. Anytime Art wants to come on, he's
anytime.
On. Anytime.
Okay, I'm gonna have to hook Katie up first.
Done. I love seeing you with the Office of the President seal and all the big flags. It's incredible.
Oh yeah.
Look at you.
Well, I really appreciate you giving the opportunity to talk about the executive order.
So tell people,
and we're gonna loop you into another event we're doing.
Whatever I can do, I got you. You got me. Because I get up every morning thinking about these things, and I can't abide by the current state of, particularly in this place we call California. I don't know what to call it anymore. It's barely the state I knew. But in any event, tell them one more time about, can they drop in on the symposium, or is it something? Is there a website? Where should people go? What can they do if they want to learn more?
We're going to be a Veterans Administration building in Philadelphia. I don't know. I got my main helper over here, Natasha. But people can't just drop in, can they? Or
will it be on C-SPAN?
We're looking at a live stream format.
Probably on C-SPAN.
We're going to have the second lady, Mrs. Pence, is there.
Okay.
Yeah.
How do we find that stream? Where should we go? Is there a website?
Well,
I'll put it up on my website if you want.
okay,
Yeah.
I'll hit you with
Last
an email.
time it was
when we get back.
C-SPAN, so maybe it's on C-SPAN, and we'll put the date
They're in
up.
Philadelphia. See, C-SPAN's in D.C.
Oh, okay.
So
Okay.
We'll put the information out there.
Okay,
we'll
well,
push it out.
appreciate you allowing me to get an opportunity to talk about this. And we're excited about the EO and the president back and supporting.
I am so excited for you in this job. I'm so excited that you got the president's attention. You got a executive order. I'm so happy. And so congratulations and whatever I mean it. If you want me in whatever you want me to do, I'm at your
Okay,
service.
we're going to stay in contact for sure.
All right, man.
So
All right,
thank you
thank
so
buddy.
much.
Okay, we'll talk
And
soon.
thank you for all your work you're doing. You're doing great.
Whatever.
work.
It's all good. You're doing the real
Okay.
stuff.
All right, you take care.
All right, buddy. So
Okay.
let me switch to the chat here. I want to give you guys a chance to interact a second. Jesse, I don't know what you mean by the moral authority. I don't know what that means. Gregory, it's my pleasure to bring Art. He's the best. He really knows what he's doing. And so
They
it's
were
good
being
to,
so silly at the beginning, though. I couldn't put any of the comments up, but then they got good. So
yeah.
it's hard, It's like being in school. You just can't help it.
Okay,
Everybody's chatting among
so
themselves.
Andrew is Andrew Ashkasvili in there. I heard that they stopped the Regeneron trial, and I'm curious why.
He said because somebody got sick.
Yeah, but what that's goes sort of without saying. But what happened? I know they also stopped the which of the was it the Eli Lilly vaccine? They stopped one of the vaccine
No,
trials
it's a different
as well.
one. It was a different one. I can't remember the name of it though.
Do you know which one it was that stopped?
No. No, I wasn't really looking at my panic porn this weekend.
Oh,
so
good.
I
Well,
didn't get it
it'll
all.
restart. I'm fairly confident. Maybe it's the Pfizer one. Johnson & Johnson. Yes, Gregory, it was the Johnson & Johnson vaccine. Excuse me, which I believe will restart soon enough. So, yes, Kelly, they have a first case of reinfection. I've seen other reinfection cases out there. One of the really interesting questions we have to ask ourselves is whether or not getting a monoclonal antibody like Regeneron might suppress our own immune system and decrease the viability of our immunity. It's really kind of an interesting thought. And so the Additics people who I've been bringing around here, I was talking to their scientists, and they believe in January they'll be able to answer that question. So I am actually studying that literature right now. It's a very interesting world of being able to assess T cell and B cell function in a meaningful way. And I think they're going to have that. They're going to have that soon. So right now we can't say, "Oh, but President Trump, you are immune." That's why we tend to hedge our bet and go, "We can't really tell. We don't really know for sure. We think so. There's antibodies, but we don't know if they're adequate." But it's kind of a nefarious infection, so we don't really know yet, and we will know that soon enough. Jesse Espino, you're asking about porn. We're talking about panic porn.
Panic porn.
Which is the fact that
Kelly,
the press.
that was Kelly Gallagher.
Oh, Kelly asked that? Well, panic porn is just the press. It's just everything.
Following that right side of your iPhone, all the news that comes up.
Yeah.
Yeah. I saw that they were, stopping it, but I don't believe everything I read.
What are you talking about now? The Regeneron
About
or the J&J?
About the vaccination trial. I don't know. I just.
You can't. It's interesting to me that you can't believe anything anymore.
I can't.
That's really fascinating because you hear me talk about all this stuff and questioning it and wondering, and now you've gotten to the point.
I'm saturated.
Yeah, I get it.
I give up. I give up.
Let's take a look at some of this.
I need a drink.
Susan, can you put up some of the states from the COVID tracking project? I want to put up Florida.
I knew you were going to do that. Oh, look at that. I came up with it. But this is actually the wrong one. This is health data. Sorry.
Yeah.
Okay, let me find it.
COVID tracking.
I'll find it. Hold
Weird. Florida had one day where they had a wild spike of 5,000 cases, though generally they're around 2,000. Their hospitalization are down. Their death rate is flat. Forget it. I'm good with that.
I found Wisconsin.
Let's put up Wisconsin. Wisconsin's been in trouble. Wisconsin needs to pay attention. Although the numbers are not that high, they just need to pay attention. So Indiana has been sort of flat or heading up, even though they opened up. So they need to,
What state were you looking for? I can jump to it here.
Let me see if I can predict who that is. Is that Wisconsin I'm looking at?
Yeah, that's Wisconsin.
Yeah. So that's Wisconsin. They had lots of mass gatherings, and they are in lots of trouble now. Look, particularly as it pertains to the hospitalization rate and even the death rate. That is no bueno. Now, the numbers aren't huge, but they are no bueno. They need to get under control. If you look at it looks like the case rate, though, is starting to plateau, I think.
This is from August. Do you want the full range?
I would like, yeah, sure. That's the full range?
Mm-hmm.
Yeah, interesting. So see, they never had an outbreak at all, which is kind of interesting that I find it fascinating that most of the cases, most of the states that are having significant surges, like Wisconsin here, never had a surge. So it's kind of wild. Here's Minnesota. Let's see how they
You want
do.
Minnesota?
Yeah, I'm just looking around. Minnesota, never really, well, they kind of had a surge. They had a surge of hospitalizations, but they're tending back up again, and they need to watch out.
But the deaths aren't
and
as
Dr.
bad.
Fauci spoke today about his concerns about how this is going to go down as the winter months hit. And this is a viable concern. This is real, we have to really
And
pay
what
attention
about
to
the
this.
mental health and the drug addiction? I mean, that's
We just
that's
talked
what
about
this
it.
is about.
That's what we've been talking about for the last hour. And, you know,
It's not good.
Ohio. Put Ohio up there, Susan. People are worried about that.
Where's the thing? I just saw.
Can you have COVID-19 without a temperature? Yes. If you listen to the latest episode of Whiskey Ginger,
I had,
my buddy Andrew Santino had it without a fever.
and we're gonna have him on the show
Yes, tomorrow. Andrew Santino on tomorrow. But
How come I can't? I just was able to skip to the.
you got to go down a
state.
little bit.
Oh,
I
here we
think.
go. You wanted, what did you want?
Ohio. Yeah.
Ohio.
How
How about Alabama?
No, in Ohio. Okay, not bad, but starting to get in the wrong direction.
But
so they
look
got
at
to
the
be careful.
deaths are down.
I know, but it's a lagger. So the hospitalization rate goes up, then the death rate goes up. So it could be they could be heading in the wrong. Certainly they need to pay attention. And then if you want to go to Alabama, that'd be okay.
Jump to state. Oh, look, I found out how to do this now. Finally, after months of doing it.
Mm-hmm. Alabama down, very low, not very low,
Really?
but plateaued. Give me the full numbers. That's
Considering
that's the last
they
90
have-
days. That's the full thing. So yeah, they had a surge, they plateaued. Kind of like not all that different than California, which is interesting.
Yeah, but California has like 3,000 people.
We'll show
new cases
California,
a day, but
bigger numbers,
We're big people.
but we're big people.
Bigger people.
Show California, the full thing too, the full Monty on California.
They have B ratings on their.
I
on
know, of course, California. So there we are now. Look, hospitalization down, death rate down, everything going down. The state
at
health
that.
director guaranteed a 90% increase in hospitalization by next week. I'm sorry, you're wrong. I'd
Oh,
like an
boy.
apology and an adjustment of your position,
Yeah.
as opposed to continued sanctimonious telling the people of California that they're misbehaving. They've been talking about a Labor Day surge for 6 weeks, as though it had anything to do with anything.
Look at
You're
that.
wasting your time.
I know.
So there's the full picture, and you see we had our surge this summer, and now we're on our way
That's
back
when you
down. So
don't read or listen to the news.
that's why you, Susan, don't believe anything you hear.
I don't.
Smart.
I'm
Smart.
I
Smart.
called her out the first week I saw her up
No,
there
this
on
was
podium.
this was the state director.
Oh, the state.
Yeah.
Oh, God.
Do I think we'll have more H1N1 deaths, Kelly Gallagher? I've noticed that I'm starting to worry about H1N1 because of people not getting their flu shots. So yes, I do think we'll have some H1N1 around. Andrew, IHME projecting over 3 million deaths now worldwide. And Andrew, what's your point? Andrew, why don't you call us
So,
really?
Drew, here's New York.
And so New York it's ticking up again. If you
Look
look
at the new deaths.
it's
like-
nothing. It's nothing. They've had it. But go do 90 days, and I'm going to show you something.
That is 90.
Nope, that's the full thing.
No, it's 90. Okay.
Yeah. So you can see from a 90-day standpoint, they're going the wrong
A little bit.
direction. It's not big numbers, but you certainly don't.
10 deaths. I
No,
mean,
look at the hospitalizations. You don't want
new
to.
cases, hospitalizations. They have like 800.
I know, but
923 in the
you
whole
want to
state.
see it kind of plateau out again. So, Andrew,
Yeah,
I'm
but
looking
it's
for
getting
you.
cold there, and it's
I know.
kids are going back to
Garbage.
school.
Thank you, Andrew Ashkenazi. Yeah, that's what I was hoping you were pointing out. It is garbage. Andrew, do you know why they stopped the Regeneron study? What was the illness they saw? Because it does not seem like a type of a treatment that would have much in the way of peculiar illnesses. Okay, Kelly Gallagher. They say if 80% of us wore masks, that would save 90,000 lives in the next 3 months. Well, Kelly Gallagher, I'm sorry to tell you that a study came out today that said of people who get COVID, 85% say they wear masks all the time. 85%. Now, that doesn't mean Kelly Victory has gone out there espousing victory, saying, look, masks don't work. That's the science.
Yeah, it's
Andrew's
not
saying they didn't
scientific.
specify, so probably no big deal. I agree with you. But here's the deal about that 85% data. It's a false equivalence.
Do you believe that too?
So here's the deal. So if you're going to get, pretty much everybody's wearing masks these days, right? So if you're going to get COVID, you probably wore a mask. If you got COVID, it's probably going to be in your home where you don't wear a mask. So mask wearing doesn't affect the transmission because most of the transmission occurs in the home. The question is, does mask wearing slow outbreaks? not does it prevent a given individual from getting the disease. We know it doesn't prevent you. Wearing the mask on the outside, you still can get it. You can. It's just the way it is. But you're certainly not transmitting it to other people as likely, and you are slowing the transmission and you're flattening the curve. That's been our goal all along. So it doesn't mean that masks don't work. Susan, I need to have a conversation with Kelly Victory about that.
Okay, when?
I don't know. It could be a short one. But don't be, it's a great example of data interpretation. The headline is 85% of people with COVID wear their mask. It's like, yeah, because it happens where you take your mask off, or it happens in a restaurant where you're eating with your mask off. But putting the mask on prevents you from transmitting it once you got it, and probably reducing the rate of spread reducing the R naught. So you don't spread to as many people as quickly. The mask wearing is a good thing.
How is our COVID-laden friends Colleen Williams and John Dudley?
I have not touched base. I may call them. I'm not sure if they want that public.
Well,
now it is.
C'est la vie. These people do not know who that is.
So watch. Let's see.
Well, she doesn't have it. She just has to quarantine. He has it though. I want to interview him and see how he's doing.
Okay. Let me wrap things up, guys. I got to go do the Fox 11 deal.
Yeah, you're back tonight.
Yeah, I'm back tonight.
Boop, boop.
I can tell you what we're going to talk about. I just got while we were sitting here, talk about the Lakers. We're going to talk about possibly Disneyland being closer to opening, guidelines for Halloween, and we're going to talk to Ventura County.
You haven't talked about the Who with them.
The Who?
The Who coming
Will they
up.
yeah, we're going to talk about that. Trust me.
The Who?
Yeah. And we're going to talk about the drug companies pausing the trials and that kind of thing.
And then we got the ginger whiskey special
tomorrow.
Yeah, it's so funny. I emailed him and I said I sent him the banner and everything goes. He emails back with a glass of whiskey and a redheaded person.
That's him.
Yeah,
That's
like a little like emoji thing. It's so cute. I like him.
He's a very good guy.
I really like him.
Hopefully he's feeling better. We'll find out. He had COVID. I'm on his podcast right now, and he will be on our stream tomorrow.
Yeah, we're gonna follow up and.
Hey, I am starting a site.
Take calls.
I am starting I'm starting a community called Locals. I'm not have it fully set up yet, but the next few days we're going to activate it, and you can find me there. It's going to be a really interesting.
He's already promoting it.
yeah. It's.
I have to go.
Susan has to help me set it up.
I know.
But it's a place where we can really gather and have like direct conversation and community building. It's really kind of a cool thing. And I'm hoping it as good as I think it's going to be. So see me at Locals. And
if you know anybody who needs mental health treatment in in California, check out our sponsor, amfmtreatment.com. The ad will be at the end. And also for recovery, abetterliferecovery.com.
I've spoken to the clinicians of these programs.
They wouldn't let me play it at the beginning, so
they're very good.
We went right into the show.
I don't know if the ONDCP has policy issues. I didn't clarify that with them before. So we can do it now at the end. Now it's our thing. Yeah.
Well, it basically just went to him. Something happened with the tape, so it's just going to be an intro. Hopefully, his name was caught in there at the beginning.
That's fine. Okay, so we'll show you those little.
A lot more information in between, so it's good.
More than you need to know. Thank you all for hanging out. We'll be here tomorrow. What time? 2:00? Are we early?
No, 3 p.m.
3 p.m. tomorrow with.
But can you come early to do some ads?
I sure can.
Yeah, go to like 2:00 or 1:30 with Caleb.
No. 2:00.
All right. Maybe we can slap those together pretty fast.
Yes.
Because you don't have time afterwards.
We have an hour to put them together, so we'll do it.
Yeah, well, he has to say. Okay, I'll tell him.
Okay.
But you can't come any earlier.
I'm actually going to be here at 2:30. Now I'm looking at it. It's 2:30.
Ooh, that's not good.
That's what we're going to do.
Well,
He can put them all on the prompter and stuff, and we'll do it. So.
All right.
All right. Thank you, guys. We'll see you tomorrow.
Or maybe right after the show.
Yeah, I can do it after.
This is okay.
Okay. See you tomorrow.
All right. Bye.
The World Health Organization estimates that each year approximately 1 million people take their own life. That's one death every 40 seconds. Experts predicted numbers would peak in 2020, but no one could have imagined the devastation brought on by COVID-19. During the coronavirus pandemic, you may experience anxiety, sadness, and loneliness. Existing mental health conditions, including severe anxiety and major depression, may worsen. If you're feeling hopeless, contemplating self-harm, or you're concerned about someone else, I'm here to tell you there is hope. Mission for Michael is dedicated to helping clients achieve complete inner and outer transformation. Mission for Michael is the premier resource for intensive mental health treatment in Southern California. With an astonishing 2-to-1 client-to-staff ratio, each client in their facility receives individual care 24 hours a day, overseen by a team of all doctorate or master's level clinicians. With a focus on evidence-based treatment, along with personalized and compassionate care, they offer mental health treatment that can change lives. If you're suffering from mental illness or you're concerned about a loved one, go to amfmtreatment.com. Again, that's a mission for Michael, amfmtreatment.com, or call 866-581-4401. Again, that is 866-581-4401. According to SAMHSA's National Survey on Drug Use and Health, approximately 20.3 million people above the age 12 suffer from substance use disorder. Incredible. The disease of addiction takes an average of 130 Americans every day. Sadly, the opioid crisis, which many consider the worst pandemic of our time, has been even further perpetuated by the spread of COVID-19. Since the start of the coronavirus outbreak, drug overdoses have increased by 18%. Factors like economic stress and social isolation have led to increased depression and unnecessary deaths. A Better Life Recovery is a premier addiction treatment center in Southern California, offering one of the most highly regarded and comprehensive addiction treatment programs in the United States. Dedicated to helping its clients achieve complete inner and outer transformation, they offer a 45 to 90-day program custom tailored to meet the needs of each individual client. Long-term is the way to go. Many of A Better Life's clients elect to stay up to 9 months to receive additional support. A Better Life Recovery will do whatever it takes for as long as it takes to ensure the success of every client. Are you ready for a better life? Go to abetterliferecovery.com or call 866-581-4401 now.
Real talk.
Headlines have become sickening. They become poisonous.
Dissecting headlines.
Defying state orders. Sheriff Bianco not enforcing what the governor is saying.
Dialed in with decision makers.
Clarify what you actually meant.
Get the answers you need.
At the beginning of this, we were told, don't wear a mask. Is this really helping?
Expect a different kind of newscast. Fox Sullivan News Special Report. Weeknights at 7.